Hey everybody, we're going to talk here about pancreatic cancer, and this is a very feared condition. Unfortunately, it has a very poor rate of survival, and it does come up on your exam because there are some pretty unique features that they can test on. And because it is something that is unfortunately fairly common, it is very much fair game for your exam. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button in the upper right hand corner. I appreciate all the contributions that I can get to help offset the cost of these videos, and I thank all those of you who have already donated. Okay, so here's some anatomy. On step 2 and 3, anatomy is not super duper important, but we'll just pay attention here to the different parts of the pancreas. The tail is over by the spleen. The spleen would be kind of right there. And then the head sort of abuts against the duodenum. And notice the common bile duct comes down here sort of through the pancreas. The pancreatic duct joins it, and then eventually it then empties into the duodenum. So that whole system is connected, and that's why when we think about pancreatitis, one of the causes is gallstones. You get a gallstone from the gallbladder, it comes down here, blocks up that pancreatic duct. You can have both a choledocholithiasis, where you've got a stone in the common bile duct, which can also block the pancreatic duct and then cause pancreatitis. So there's a little bit of interplay between the biliary ductal system with the liver and the gallbladder, along with the pancreas. And eventually all those secretions will empty through the same path into the duodenum. This is just your anatomy here. Really not a whole lot more to say. All right, let's start with a vignette. This is a classic case. A 58-year-old man presents to your clinic complaining of abdominal pain and shortness of breath. He says he doesn't remember when it started, but both problems have been going on for at least a month or two. He points to his epigastric area. That's like kind of your belly button, right? He's not had any changes in bowel habits or color, nor has he had any related nausea or vomiting. He describes the pain as dull, as a 4 out of 10. It radiates to his back, and it's worse when laying down. He denies cough, wheezing, and contact with sick. There is a 30-pack year smoking history. Patient consumes alcohol only a few times per year. He's got a past medical history of type 2 diabetes, which is controlled on metformin. On physical exam, you note mild epigastric tenderness, scleral icterus, mild jaundice, and a small palpable mass in the right upper quadrant. No distension or rigidity, no hepatosplenomegaly, no peritoneal signs. Rectal exam is negative for masses or stool guaiac. Lungs are clear to auscultations and off-field, and the heart rate and rhythm are regular. There is paleness of the nail beds and the buccal mucous membranes. He has lost 25 pounds since his last visit 6 months ago. Okay, so what do we see here? Well, first of all, let's just run through this real quick. So the chief complaint is abdominal pain. So we're thinking something in the abdomen, right? So that's where you want to start. When you got a patient who's got a complaint, and that complaint is pain, you want to think the region and then start to think about the organs and the vasculature and the muscles and so forth. He doesn't know when it started. So what does that tell you? It's probably not from an injury. It's probably from something that has a very slow process. So ruptured aortic aneurysm? No. Tumors? Sure. So he points to the epigastric area, no surprise. No changes in bowel habit, so not any kind of obstruction. No changes in color. He doesn't have any related nausea or vomiting, which tends to come with cholecystitis. He describes the pain as dull and as a 4 out of 10. It radiates to his back. So we see that with the pancreas, right? The pancreas sits right behind the stomach. And so anytime you have pain that is in that vicinity of the pancreas, whether that be pancreatitis, whether that be a ruptured aortic aneurysm, that's going to radiate to the back. Anything in that sort of region. He's got a 30-pack year smoking history. We're going to see how that comes up. He's got type 2 diabetes, so he's probably overweight, but we don't know. epigastric tenderness, scleral icterus, and mild jaundice. So there's something biliary going on here. Maybe a blockage, something biliary though. And you notice a small palpable mass in the right upper quadrant. Okay, is the pancreas in the right upper quadrant? No. What's in the right upper quadrant? The liver, the gallbladder. What happens if something blocks the bile duct? That gallbladder is going to get big because it has no way of pumping what's in it out. Okay? No distension or rigidity, no hepatosplenomegaly, no peritoneal sign. So nothing is burst, nothing's got a hole in it. The no hepatosplenomegaly means there's no vascular blockage. Rectal exam is negative for masses to a Guaiac, and everything else is pretty much normal. There's paleness of the nail beds. What does that tell you? Anemia. Anemia. Lots of things can cause anemia. It could be a subtle bleed, or it could be an anemia of chronic disease, which could be cancer. And he's lost 25 pounds. Whenever you hear anemia and lost weight, you have to be thinking cancer. That could be colon cancer. It could be liver cancer. It could be pancreatic cancer. We don't know. But when you talk about losing weight unintentionally and having anemia, you have to be thinking cancer. Okay, so what are we going to do? Well, we're going to get a CBC because we know he's anemic. A CMP. So a CMP is basically your metabolic profile plus liver function tests and then some other things. So you could just say BMP plus liver function tests if you want. Amylase and lipase. Anytime you've got abdominal pain that radiates to the back, you need to be thinking pancreas. So get amylase and lipase, chest x-ray, and abdominal x-ray. You know, maybe it's a blockage. We don't know. So get a chest x-ray and abdominal x-ray. And what do we find? Well, we find the anemia. The liver panels come back. The ALT and AST only have very mild elevations. So what that tells us is it's probably not a hepatitis or any kind of problem with the cells of the liver. ALP is 205, so that's fairly significant. When you see an ALK phos that is elevated, you need to be thinking of the biliary ductal system. Okay, maybe it's a common bile duct stone. Maybe it's a pancreatic cancer. Maybe it's a cholangiocarcinoma. But it's something in the bile duct. Those bile duct cells release ALK phos. So when you see an elevated ALK phos, you need to be thinking something in or around the bile duct. Total bilirubin, 4.2. So when you have an elevated total bilirubin, and that conjugated bilirubin is elevated, you've got to be thinking blockage. Blockage, blockage, blockage. Amylase is normal. What does that tell you? The pancreas itself is okay. You don't have any damage to the pancreas. You're not dealing with an acute pancreatitis. The chest x-ray is unremarkable. The abdominal x-ray is unremarkable. We kind of suspected that based on our vignette. So what is the best next step? Well, what we are thinking here, like I said, blockage, blockage, blockage. When there is a blockage, you need to do imaging. What's the best imaging to do? Ultrasound. Why ultrasound? Because ultrasound is really good at seeing anatomy, like gross anatomy. So ducts and bowel and, you know, the uterus and anything that you don't need a lot of resolution. You just want to see, is it dilated? Is there something in it? That's what an abdominal ultrasound is good for. You could do a CT, but abdominal or right upper quadrant ultrasound is the best test when you think there may be something going on in the biliary ducts. So you've got a little kid who's got high conjugated bilirubin and you think maybe it's biliary atresia. Ultrasound it. You got a woman with right upper quadrant pain. Ultrasound it. Same thing here. Okay, you've got epigastric pain with what looks like, based on the ALK phos and the total bilirubin, is some sort of biliary blockage. Got to do an ultrasound. What do we find with the ultrasound? Dilation of the gallbladder. That explains our right upper quadrant mass. No wall thickening, no gallstones visible. So this is not a choledocholithiasis. It's not a cholecystitis. Markedly dilated common bile duct. What does that mean? That means the mass is going to be down here. in this area, right? Because the common bile duct is right here. Everything before the blockage is going to be dilated and everything after it is going to be collapsed. So if you have a dilated common bile duct, that blockage is pretty darn close to the duodenum. And the typical place for that is going to be the head of the pancreas. Sure, you could have a stone way down here towards the papilla, but the thing you've got to be thinking is cancer, 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 especially in the context of that anemia. So then we see that there's a 2 centimeter hypoechoic mass at the head of the pancreas and a dilated pancreatic duct. So that's telling us that there's a blockage in front of the pancreatic duct. So we're kind of getting an idea now, based on this ultrasound, of where exactly this blockage is. And it's likely around the head of the pancreas. And that, in context with the anemia and the weight loss and the history, being a smoker, being a diabetic, this all points to pancreatic cancer. So our next step is to get an abdominal CT. You get the abdominal CT, you will pretty much have your diagnosis based on the fact that you have a mass in the pancreas. Now, there are benign tumors of the pancreas, insulinomas for instance, but typically that is going to give you a more unique history. So after you do that abdominal CT, well, what do we have here? We've got an obstructive jaundice, elevated ALK Phos, elevated conjugated bilirubin, jaundice, that is obstructive jaundice. And so anytime you have obstructive jaundice, you need to find out what's obstructing it and ideally relieve that obstruction. And so what do we do to look inside the bile ducts? We do an ERCP. And the nice thing about ERCP is we can also do a biopsy while we're in there. And if we have a mass in the pancreas, you bet we're going to be biopsying that. And another thing that you're going to want to do is get a titer of CA19-9, which is the marker for pancreatic cancer. So pancreatic cancer, also known as pancreatic adenocarcinoma, is an infiltrating ductal carcinoma of the pancreas. That is 90% of all cancers of the pancreas. The most common presentation is a middle-aged to older person with obstructive jaundice and weight loss, just like in our history. But as we're going to see, younger people can get pancreatic cancer too. It accounts for 3.3% of new cancer diagnoses in the US, but it is the third or fourth leading cause of cancer death in both men and women, depending on the stats that you read. Risk factors. The number one risk factor is smoking. Smoking. You have to know that for your exam, because what they're going to do is they're going to give you a vignette just like I gave you, and then they're going to say, which of the following modifiable risk factors could or would be most likely to have prevented this? And the answer would be smoking cessation. Okay, so when we're talking about smoking causing cancer, we ain't just talking about lung cancer here. We are talking about pancreatic cancer, which is one of the worst cancers you can get, probably second only to glioblastoma. I mean, this is really bad. Other things include older age, obesity, so that may kind of follow with diabetes, chronic pancreatitis. So if this is a person who's maybe an alcoholic who drinks and drinks and drinks and has had multiple bouts of acute pancreatitis and now they've got malabsorption and diabetes, that is a risk factor. Familial cancer syndromes, things you don't see too much like Peutz-Jeghers, think of the freckling on the lips. Lynch syndrome, remember ovarian cancer comes with that too, endometrial cancer. First degree relative with pancreatic cancer, and then of course the BRCA mutation. Think of family history of early breast cancer, early ovarian cancer. 90% of patients present with non-resectable, locally advanced metastatic disease. That cancer is either spread to other organs or is wrapped up around the vessels, and there's nothing we can do to get that cancer out. The prognosis is based on stage. Okay, so this is not a cancer that in and of itself is deadly. The problem is, by the time it causes symptoms, it is so far progressed that we can't do anything about it. That is the frustrating thing about this cancer. It's not like skin cancer, which you can see fairly quickly if you're paying attention. It's not like even esophageal cancer, that once that thing just gets a little bit big enough, it starts to cause obstructive symptoms. It's not like lung cancer, which will cause hemoptysis early. This is something that by the time it causes symptoms, it is usually too late. The 5-year survival is 20%, and then if it is metastatic, typically that is 3 to 6 months median survival. Classically, the pancreatic cancer patient presents with an obstructive, painless jaundice. Okay, so we know about obstructive, painful jaundice, right? That's our choledochal lithiasis, common bile duct stone. That is painful because that is all of the sudden. That's all of the sudden, and it causes inflammation because of the blockage and potentially cholangitis behind it. With a pancreatic tumor, it grows so slowly and so insidiously that yes, it does block, but everything behind it sort of has time to adapt. And so it doesn't really cause pain, but it does cause obstruction, and anything that causes obstruction in the bile duct is going to cause jaundice. There may be weight loss. There often is. It's just cachexia. And then on ultrasound, the gallbladder is found to be dilated and thin-walled, and that is that mass in the right upper quadrant. So again, what happens here is you have a blockage, but instead of developing a cholangitis, the system has time to adapt, and that gallbladder will get big to adapt. So instead of seeing a tiny little painful gallbladder, you'll see a big, painless gallbladder. 65% of adenocarcinomas are in the head. That's actually kind of a good thing because that's more resectable. So the symptoms, painless jaundice, unintended weight loss, like most cancers, mid-epigastric pain, usually worse when laying down and when eating because that's when that bile duct system is very active. Migratory thrombophlebitis or Trousseau's sign. So you get thrombophlebitis in different vessels at different times. Okay, so kind of like the migratory polyarthralgias where you wake up with joint pain in your fingers one day and then in your knee the next day and then in your toes the day after that. Kind of the same thing here. You get thrombophlebitis in different areas and it can't really predict it. The Virchow node or the Sister Mary Joseph node may be present. That goes with a lot of GI cancers, not super specific. Ascites may be present in some patients because of the malignancy, though, not because of portal hypertension. So what I believe then is going on there is that you have seeding, and that's drawing fluid out, causing a malignant ascites. So the SAG is going to be less than 1.1. Because the ascites has more protein in it than you would if you had a portal hypertension. When you suspect pancreatic cancer, the best initial diagnostic step is an ultrasound. And that is really because we see obstructive jaundice symptoms. Okay, obstructive jaundice, you've got to be thinking about pancreatic cancer. Now, this is what your ultrasound will look like. Notice how big this gallbladder is, right? Gallbladders usually are kind of like that. They're really tiny. And the walls are, I mean, you can typically barely see the lumen of the gallbladder. It's relatively small. This is a very thin-walled and dilated gallbladder. You can see some sludge in it. So, there's really nothing odd about this gallbladder other than it's dilated and the walls are stretched out. So what we're looking for when we do these ultrasounds is not so much the tumor itself, but more this Courvoisier sign, a dilated, painless gallbladder. If you had a dilated gallbladder due to a stone, that would hurt, right? So that would not fit with this. But a dilated, painless gallbladder is very, very, very suspicious for some sort of cancer. And so pancreatic cancer is the big one. It is more common than cholangiocarcinoma. All right. So here is a really good picture of a normal gallbladder. This is a little bit fibrotic, but this is sort of more the size you would see in the gallbladder, except the wall here is a little bit thicker because it's fibrotic. But you can see here, relatively small gallbladder. Versus here, where you can see the gallbladder is dilated and the wall is much thinner. So this is cancer until proven otherwise. Here, again, you can see here, very dilated gallbladder. Now, once you still suspect pancreatic cancer based on your ultrasound, then the next step is to get a CT, because that's going to give you a much better visualization of the mass itself. Because really what we're doing with the ultrasound is we're not so much looking for the tumor, we're looking at the ductal system, which includes the gallbladder, to see if there's dilation, because that is a big hint. So the next step will be a CT to get a better visualization of the mass, and you can also check for metastasis. The tumor marker for pancreatic cancer is CA19-9. Please, please, please remember that. It is very useful for identifying recurrence in the patient where, maybe we caught it early enough and we're keeping an eye on them. Further workup, biopsy is not required if you know you're going to be doing a Whipple procedure, if you're going to be, taking the tumor out. But it is required for non-resectable tumors because we need that to plan chemotherapy. All right, so here you can see the mass at the head of the pancreas. Here's your head here. It's kind of compressed in. So again, here you can see the mass, and then you can also see the common bile duct here. And then this is the pancreatic duct. The pancreatic duct kind of runs along in the middle of the pancreas. And you can see, typically you can't really see it that great, but here you can see right in between these two lines here, you can see that duct. Okay, so here you can see a mass at the tail of the pancreas, another place it can be. And here you can see you've got this, this mass here. So the treatment, ideally resection, but we can't resect if there's metastasis because we're going to have to do chemotherapy. And then you can't resect if there's occlusion or encapsulation, if you will, of the major vessels. So the celiac vessels, the mesenteric artery, the mesenteric vein, the portal vein. If there's occlusion or encasement of those vessels, it is unresectable. If resection is possible, the Whipple procedure. Most pancreatic tumors are in the head, so we'll do the Whipple procedure. It's a very complex procedure. People typically don't do very well after it, but some people do. I've got a friend whose dad had a Whipple procedure like 10, 15 years ago and is still around. So some people do fine, but it is a very, very intense surgery. If it's the body or the tail, you'll do a distal pancreatectomy and a splenectomy. Remember, the spleen is so close to the pancreas. And then that would be followed by chemotherapy. Now, if resection is not possible, it's palliative care. So what you're going to do is you're going to try to reduce the symptoms by opening up the bile duct. You can do that by ERCP. You can do a gastric bypass if there's obstruction of the gastric outlet. And then, of course, pain management. So this is the Whipple procedure. You can look more at this if you want. You probably won't be tested on it, but what you do need to know is that the Whipple procedure, you just associate that with pancreatic cancer because that's really one of the major areas that we do this. There are other applications for the Whipple procedure, but pancreatic cancer is really the big one. And here you can see another picture. We're taking out a lot of stuff. You can see why this would be a really serious surgery. This is my uncle. Actually, it's my mom's sister's husband. He passed away of pancreatic cancer only in his early 40s. So this is not just a disease of older people. Median is 60s, 70s, but this can happen to younger people too. Obviously, you can see here he's not overweight. Maybe a little, but he's not overweight. He wasn't a drinker. I believe he smoked, but not a whole lot. There's me right there. So I was only 7, 8 years old here, my little sister. But yeah, he was only 44. So very sad. All right, let's recap. Pancreatic cancer presents as painless obstructive jaundice, epigastric pain, typically worse while laying down, and often weight loss due to cachexia. The leading risk factor is smoking. Best initial test, because you've got symptoms of pancreatic cancer, or I should say obstructive jaundice, is going to be an abdominal ultrasound. That should then be followed by an abdominal CT if the suspicion continues. CA19-9 is the tumor marker and should be ordered as part of the workup. Migratory thrombophlebitis comes up all the time on your test. That's Trousseau syndrome. That is an important paraneoplastic syndrome. If you got migratory thrombophlebitis, you better be looking in the abdomen for a cancer. Pancreatic cancer being a big one. Most patients are not candidates for resection. Those who are get the Whipple procedure. If the tumor is in the head of the pancreas, non-resectable disease gets palliative care, and survival, unfortunately, is poor.